Welcome to the annual AA Tony Travill debate. This is the 17th debate, and it's really grown over time and has really become one of the most entertaining and popular events in the entire faculty. This is my, it's hard to believe, 6th Travill debate as Dean, and I'm always impressed by the quality of the debaters, by the interest in the topics, and without fail, the dialogue is clever, it's articulate, and always, and is a good thing, with a splash of humor. To start off the evening, I wouldn't mind calling on our former dean, David Walker, to tell us a little bit about Tony Travill, about the history of the debate, and a bit about the family. Thank you.
Mr. Dean, thank you. This is where I steal your notes and walk back to my chair. Mr. Dean, Andy and Louise Travill, it's good for you to be here. Welcome. Welcome everybody else. I think Chris asked me to do this because I'm probably the last living person who had Tony Travill as a teacher. Was anybody else in the audience remember Tony? Oh, thank God. Tony Travill was born and raised in England and read medicine at the London Hospital Medical School. He served as aircrew in the RAF in World War II. He was tail gunner in a bomber squadron, where life expectancy was statistically considerably less than the required number of sorties. He used to love telling that story. He was living a dream. He emigrated to Canada in 1957, and a residency year in Montreal followed. He then went to Orillia as a family physician, thence to Queen's to study anatomy under the famed John Basmagian. Following further graduate work at Creighton University in Omaha, he returned to Queen's. His career here blossomed, and he served as head of the department from 1969 to 1978. As a side job, he became the faculty historian, medicine at Queen's, 1854 to 1920, and just a few Queen's medical profiles. He taught generations of health professional and basic science students in a most engaging, if not slightly unsettling, and intensely entertaining fashion. I remember his tendency to show a slide of a section of some anatomical structure, delighting in asking students at random, "What is it and do you have one?" Answering yes to a bit of what turned out to be ovary certainly propelled me to study considerably harder. Tony loved to argue on any point, in any context, and with great ability. He would regularly assume the very opposite position of his own opinion simply to enjoy the discussion. Delightfully and respectfully provocative, he showed how challenging dogma could change opinion without rancor, offense, or temper, just what universities are for. He made us think. Thus, we remember Tony Travill through this forum of the debate named in his honor. He would have loved it. Thank you very much.
Well, thank you, David. Much appreciated. Again, I'd like to especially welcome the Travill family who've traveled every year for this event. You've been here for every event since 1997. We're thrilled to have you. I'd also like to remind everybody that after tonight's debate, we'll welcome everybody at the University Club, just to the left, for a little reception. Before I introduce the speakers, please join me in thanking the Travill Debate Committee, who worked very hard to organize this event, narrowing down the topics and then recruiting the debaters. The committee includes both students and faculty members, most of whom are former debaters themselves. So David Walker, Michael Adams, Dan Howes, Chris Smith, David Taylor, and Ross Walker from the faculty, Eve Purdy, Mark Brusenko, Sarah Tassir Ben-Sharif, Faye Q, and Sophie Palmer from the student group, all led ably by the wonderful and terrific Chris Rank. Chris, thank you for taking this on this year. I know Jackie's a hard act to follow, but thank you so much for doing such a wonderful job, and thank your entire committee. Today's debaters will join next year's committee, so we're always looking for interesting topics and suggestions for future debaters, so if anything comes to mind while you're listening, please let us know. 18th century French moralist Joseph Joubert said, "It's better to debate a question without settling it than to settle a question without debating it." So many things, like tonight, in medicine are not clear, and medical professionals and scientists have a responsibility to see both sides of a dilemma, to give each due consideration and sufficient airtime. While our debaters always engage with passion, I think we need to realize in terms of the terms of engagement tonight that the positions that they adopt tonight are not necessarily the ones they actually believe in. So in fact, the plaque, which is over there for tonight's debate, already has all four debaters' names on it. So, it indicates that we're really not taking sides. But we are going to ask you to vote for one of the teams. So when you do, divorce yourself from your opinions on the proposition. It's all about the quality of the argument. After the debate, we'll ask for a show of hands, but we'll also start with a preliminary biopsy, if you will, of where the audience is currently. So it's time to meet our debaters. And they're going to argue the proposition, and it's an interesting one. Be it resolved that evidence-based medicine is an affront to clinical acumen. And if I'm remembering correctly, one of our debaters' parents is well respected and well known for the field of evidence-based medicine, but we won't let that come into play tonight. Arguing on the yay side, and it's just apt that we have a surgeon, in fact, the head of surgery, debating the yay side that evidence-based medicine is an affront, if you will, to clinical acumen, and that's John Rudan. John is the head of surgery. He's the director of clinical research within our Human Mobility Research Center, which he founded many years ago, and is currently the Britton Smith Chair in Surgery. John's partner is Thomas Cron. Thomas is a third-year medical student in the class of 2017. Tom's a lifelong Queen's student, as he's previously completed an honors Bachelor of Science in Life Sciences here, as well as a master's in microbiology and immunology. In medical school, he's developed a passion for debate, whether through ethics and law teaching, history of medicine curriculars and extracurriculars, writing for the Queen's Medical Review, engaging in global health, engaging in global health forums, or participating in discussions during class and small group learning. The opponents on the nay side of the proposition are Dr. Stephen Archer. Dr. Archer is our head of medicine. He's a world-renowned cardiologist and cardiac scientist with a special interest in pulmonary hypertension. He has a Tier 1 Canada Research Chair in mitochondrial dynamics, and importantly, he and Dr. Rudan are friends for a long time. In fact, their friendship dates back to Queen's Meds 81, where they were classmates. Their friendship's going to end tonight after, is it 25 years or 30 years? 35 years, yeah. Dr. Archer's partner is Jennifer Fu, and she's in the Queen's Medical class of 2018. Jennifer grew up in London, Ontario, and holds a 3-year Bachelor of Medical Sciences degree from Western University. She was also the 2015 recipient, I hope I'm pronouncing this correct, of the Mock Gainsland Foundation of Canada Summer Studentship, which led her, importantly, to join Dr. Archer's lab as a research student in June 2015. So the debate rules are strict. The yay side will open with 10 minutes. The nay side will follow with 10 minutes. And then the process will be repeated once, but cumulatively 10 minutes for each of the yay and nay side at the end. At the end, they'll each have 2 minutes to sum up. We keep a tight clock. When the time is up, our timekeeper will loudly bang the Travill debate gavel to drown out the unruly debaters. If they refuse to stop talking, the audience will be invited to join in or physically remove him or her from the podium. And the keeper of the time clock is Hollis Roth, a fourth-year medical student. Hollis, you need to be mean and mean-spirited with your gavel. And it's an interesting gavel at that. It was made for the debate specifically by Chaim Berman, the grandfather of Dr. Herschel Berman of the Queen's Medical Class of 1998. And it's been used ever since. So we begin with a show of hands, sort of giving us a sense of your current biases. How many of you have arrived this evening supporting the resolution? And that resolution is that, be it resolved, evidence-based medicine is an affront to clinical acumen. Okay, well, we got a smattering of affronts. How many of you, we hope it's the rest of you, are on the nay side that you don't believe it's a clinical affront? Okay, well, the yay side has a job to do, and the nay side can't do much better than it already stands. All right. Now, we would normally just proceed to the debate, but we have a special request from the Chair of Medicine, and you must know that the Dean of Health Sciences works for the Chair of Medicine. So obviously, we'll acquiesce to the request and turn the podium over to Dr. Archer.
Thank you, Richard. Well, I just want to address briefly, I know this breaks tradition, but I just want to say something to Dr. Redan, as my classmate, Meds 81. We showed up here in full regalia, and John, it just seems as friends and colleagues for so many years that we should just relax and get into something more comfortable, which reflects the fact that we just want to enjoy this and we're not trying to suck you in. So I don't know if you'd be willing, I would just like to symbolically take off this robe, and I encourage you to do the same. Something more comfortable.
And on this I can agree.
Now that everybody's in their jeans and sweatshirts, we can start debate. So first, I'd like to call on Dr. Redan from the Yay team. No, okay, almost Dr. Cron. Yeah.
Hello? Okay. So, good evening. In 1990, the Evidence-Based Medicine Working Group announced a paradigm shift in the teaching and practice of clinical medicine. Traditional sources of information in medical knowledge, including the primacy of the expert, would be replaced by evidence generated by high-quality randomized controlled trials and observational studies. The results of clinical epidemiology would be used in conjunction with physician expertise and the wishes of patients and applied to clinical practice. Evidence-based medicine, or EBM, quickly became an energetic intellectual community committed to making clinical practice more scientific and empirically grounded, thereby achieving safer, more consistent, and cost-effective care. Evidence-based medicine, now the dominant paradigm, can be defined as the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. The practice of evidence-based medicine means integrating individual clinical expertise with the best available clinical evidence from systematic research. In common medical parlance, EBM mainly denotes the use of clinical practice guidelines to disseminate proven diagnostic and therapeutic knowledge. Our position is that evidence-based medicine is an affront or a deliberate act or display of disrespect to clinical acumen. Clinical acumen, defined as the proficiency and judgment that individual clinicians acquire through clinical experience and practice, constitutes a valuable source of medical knowledge. I will argue that the EBM paradigm provides a limited route to truth and misrepresents the fundamental values of clinical medicine, necessitating the role of clinical acumen in medical decision-making. The first premise I'll be arguing is that evidence-based medicine does not constitute a complete way of knowing. It cannot replace all traditional sources of medical knowledge. Evidence-based medicine attempts to define what constitutes knowledge in medicine, focusing on evidence produced by clinical research such as randomized controlled trials and observational studies. Other forms of medical knowledge include physiologic principles, expert opinion, understanding of professional and patient values, and individual clinical experience. The purpose of considering all these sources of knowledge is to approach truth, the entire understanding of a particular clinical reality. According to the teachings of evidence-based medicine, there exists an evidence hierarchy. At the top is the systematic review and the meta-analysis, followed closely by the randomized controlled trial, and at the bottom, deliberately you might say, is expert opinion. In the EBM framework, randomized controlled trials are considered the gold standard of evidence, helping to answer a concise clinical question. However, they have several limitations in approaching this truth. Randomized controlled trials provide an average result in a highly controlled population and defined environment. They do not provide reliably generalizable knowledge and set unnecessary constraints on clinical testing. Study design choice can play a significant role in the outcome, as false dichotomies, surrogate endpoints, unrepresentative populations, and statistically overpowered trials can all favor findings of efficacy. Selective publication, confirmation bias, and the known influence of pharmaceutical funding in improving study outcomes all influence the applicability of these findings to real-world clinical practice. In attempting to define a clinical practice centered on evidence derived from clinical studies, the definition of EBM provides problematic. The process of integrating individual clinical expertise with the best available evidence remains poorly defined, as the relation of evidence to other sources of medical knowledge is not addressed. This fundamental tension underscores many of the criticisms of evidence-based medicine. Is it just a rebranding of medicine? Medicine as it's always been done, as no one would claim to practice non-evidence-based medicine, or is this a fundamental shift towards the embracing of evidence? There also exists a fundamental gap between clinical research and clinical practice. Medical practice has always been based on the personal interaction between someone in need of healing and someone who professes to heal. Public health, on the other hand, emphasizes the health of populations, attempting to benefit society as a whole. Population-based studies represent an average rather than an individualized result and speak more to public health than personal health. Collectivized data in population-based studies also tends to obscure the non-quantifiable phenomena that differ between individuals, rendering them secondary. Finally, does the application of evidence-based medicine actually improve outcomes? Interestingly, there exists a lack of direct evidence for such a critical assumption. This inability to self-critically appraise fundamentally undermines evidence-based medicine's claim to define a new medical truth. The second premise I'll be arguing is that evidence-based medicine imposes a value system that is contrary to the underlying values of clinical medicine. The practice of medicine is guided by more than evidence. It also considers the ethical values underlying interventions, including autonomy, beneficence, non-maleficence, and justice. Evidence-based medicine does not address these priorities, and by attempting to simplify decision-making, questions of beneficence and non-maleficence are distorted. Clinicians are expected to fulfill a societal mandate by maintaining an advanced knowledge base and performing a sensitive and fiduciary duty to the patient. The promotion of evidence-based guidelines imposes a conflicting value proposition on the clinician. If evidence is necessary for those practices that are beneficent, it follows that recommending treatments for which there's insufficient evidence is risky, if not hazardous. This raises the fundamental question: who is the moral burden for the decision being placed on, the guidelines or the practitioner? Evidence-based medicine also does not sufficiently value patient preferences, undermining their autonomy. Though evidence-based medicine is committed to the integration of patient values and circumstances with evidence and clinical experience, most advances in EBM have been focused on reducing bias in clinical trials and systematic reviews. Illness is a highly personalized experience. Patients are individuals too, and they want to understand their symptomatology in the context of what is known about the disease. As well, they are the ones that know their lives best and have their own individual values, which highly influence the decisions they make. Patient values or preferences are at the center of clinical medicine. The measures assessed in randomized controlled trials reduce patient choice and rarely consider preferences as primary or secondary outcomes. Clinical practice guidelines generally do not account for the spectrum of values that a patient may hold with regard to their individual care and how you can integrate these values into making a decision. In short, EBM does not factor whether the intervention offers a meaningful outcome to the patient. Risk, cost, and preventative medicine are all factors that are highly preference-specific and not accounted for in this paradigm. Questions of justice, such as resource allocation and the needs of clinical practice, are also not addressed under EBM. The choice of methodology and the topics to which we apply those methods are value-dependent notions. Values decide what questions to ask. Values decide which findings we pursue, which interventions we study in randomized controlled trials, and which therapies apply for certification. These decisions are largely driven by economic interests, founded in a belief in innovation and profit driving outcomes, better outcomes. EBM constantly privileges internally valid randomized controlled trials over more pragmatic trials, neglecting complex circumstances, resource-limited environments, rare diseases, and comorbidities. Only when we address that scientific research is a value-laden enterprise can we discuss what values should drive the resource allocation behind these studies. Values of equity, justice, and fairness are underemphasized to the detriment of certainty, rigidity, and innovation in an EBM framework. So in conclusion, we consider EBM an affront to clinical acumen because the truth that EBM provides is insufficient to inform the clinical reality, and the values that inform the EBM paradigm are distortions of those we hold dear in clinical medicine. Clinical acumen is necessary if the individual circumstances of the patient are to be tailored to one-size-fits-all evidence and true informed consent received. An EBM that respects the collaborative and circumstance-specific medical decision-making process involving the practitioner and the patient should recognize and support dynamics responsive and sensitive to changes and the individualized nature of clinical medicine. There are many challenges faced by today's physicians in evidence-based medicine. Evidence is being used to drive economic and political agendas, and the volume of evidence, especially clinical guidelines, is becoming unmanageable. Changing conceptions of disease and risk and an overemphasis on rules and guidelines is leading to management-driven rather than patient-centered care. These looming issues and the seeming inability of the proponents of EBM to change course have led some, including the editor of the BMJ, to wonder whether there is currently a crisis in EBM. Our view is that EBM does not provide guidance on how to incorporate clinical experience and patient preferences into decisions. And it provides a different approach to decision-making that speaks to a different value system than the principles clinical medicine is committed to. EBM is a tool. Its judicious application has yielded great gains in the field of medicine, providing new ways to standardize and disseminate critical breakthroughs of information. It provides us with the ability, within reason, to answer a defined and limited clinical question. But it does not absolve us as our responsibility as decision makers to consider any and all sources of evidence, including those from the patient in front of us. And it does not provide us with certainty. The challenge of EBM, then, is not whether we are applying this ideal standard of real EBM that was formulated 25 years ago, but whether the kind of medicine we are practicing is effective at addressing that patient's needs. The duty to critically reflect and ask this question is fundamental to being a skilled practitioner of the art. And the fact that we are having this discussion in itself is a strong argument for clinical acumen. Thank you very much.
Is it working? Okay. Ladies and gentlemen, friends and classmates, welcome. My name is Jennifer Fu, and I'm here with Dr. Archer today to argue against the proposition evidence-based medicine is an affront to clinical acumen. Thomas, my friend, has made a very convincing argument against evidence-based medicine. What he fails to mention is what he would have as an alternative. I think what he would have as an alternative is an acumen-based system in which clinicians' expertise is valued above everything else that is mentioned in Dr. Sackett's original definition of EBM. Evidence-based medicine, as envisioned by Dr. David Sackett, stands on three pillars. One, best available evidence. Two, a clinician's expertise, which our friend would like to refer to as acumen. And three, a patient's perspective. All three are deemed as equally important and necessary for the framework to operate. Now, arbitrarily deciding that medicine can be practiced based on acumen alone without consideration of evidence, it's like saying we can just break a leg off of a three-legged stool and expect the structure to stand. Sorry, Thomas, the law of gravity just doesn't work that way. Let me show you how the three elements of evidence, acumen, and the user's preferences fit together by telling you the story of the Oxford English Dictionary. I'm going to be drawing a comparison between the Oxford English Dictionary, which I'll be referring to as OED, and evidence-based medicine, EBM. It may seem a little odd at first that I'm making this comparison, but I do hope to convince you by the end that the methodologies used to create the OED is in fact analogous to the ones adopted by the EBM framework that keeps us up to date. Many people who have used the Oxford English Dictionary in the past know it as a reputable and reliable reference guide for the English language. What you may not have been aware of prior to today was the revolutionary way in which it was created. Prior to the OED, all dictionaries were the work of one person. They were based on acumen alone. Then came the OED, which was the very first to incorporate evidence to augment formulation of definitions. And this was done by consulting published works at the time and incorporating quotations from these works to show how each word can be used under different contexts. In the year 1857, Professor James Murray, the author of the Oxford English Dictionary, solicited all the peoples of the English-speaking world to submit their own definitions and supporting evidence showing the word's earliest use in text. And thus, the Oxford English Dictionary was no longer the brainchild of a few elite scholars. It reflected evidence and was generated based on real-world data. This process is very much analogous to the core principles of evidence-based medicine. If we regard the quotations collected as research evidence and the volunteers' ability to recognize good quality evidence as their acumen, the finished product, the Oxford English Dictionary sitting on your desks, would be roughly equivalent to today's best practice standards. Over time, we all know new words are coined and old words take up new meanings. Can you even imagine, my friends, explaining to someone 150 years ago what it would mean to tweet a message? No, sir, I assure you there are no birds, nor owls, nor witchcraft involved in this process, just none. The same applies to medicine. We today live in the 21st century. Previously unthinkable methodologies used to diagnose and treat illnesses are becoming standard practice. Just imagine the use of genetic testing in prenatal screens and all the recent excitement surrounding personalized medicine. Isn't it hard to believe that merely 12 years ago, no one had a clue what the normal sequence of the human genome looked like? Although it took 37 years to complete the first edition of the OED, it was worth the wait. Thanks to evidence-based approach, the OED remains evergreen today as it is continuously updated to reflect our evolving language. Likewise, medical practice under the EBM framework continuously evolves as knowledge is created. Thomas, my friend, may think the EBM framework is slow and requires more effort, but hard work should never be the reason to shy away from a framework that ultimately benefits patients. Because after all, the medicine we practice is patient-centered care and not physician-centered care, and the oath we all swore was to do no harm and not do less work. Plus, if EBD, evidence-based dictionary making, enabled the OED to stay relevant for the past 150 years, perhaps this is evidence in and of itself that the EBM will allow our profession to do the same. My OED-EBM comparison doesn't end here. The analogy also reminds us that subjective expertise of individuals cannot and should not replace objective evidence from research. Thomas would have you believe that doctors are capable of making clinical decisions based on their eminence. Somehow, that our lengthy training process at the title of an MD grants us wisdom to make sage decisions about every known illness, and presumably illnesses that have yet to be discovered, because why not? The problem with acumen-based medicine is that doctors often overvalue the so-called obvious facts and lock onto a diagnosis with unjustified confidence. Sir Arthur Conan Doyle, physician and mastermind behind the Sherlock Holmes series, once wrote, "There's nothing more deceptive than an obvious fact." The truth is, because we are humans, we do make mistakes. And since we're dealing with patients, a population in literally its most vulnerable state, mistakes can be detrimental. They can mean life or death. My classmates in the audience, shout out to you guys, will remember a recent lecture we had by Dr. Murray on cognitive biases in medical decision making, in which we were taught 50 ways our opinions and perceptions may falsely guide us. To name a few, these include anchoring, the tendency to lock onto salient features in the patient's initial presentation early in the diagnostic process and fail to adjust it in light of later information. This also includes confirmation bias, the tendency to remember confirming evidence to support a diagnosis more readily than contrary evidence that refute it, even if the latter is more persuasive and more definitive. Archie Cochrane, another pioneer of EBM, and the man after whom Cochrane reviews are named, noted in 1972 that commonly used therapies of the day had not been evaluated. He believed that medicine needed to be more evidence-based and less wasteful of limited resources. This system would allow us to refresh our knowledge base by incorporating newer and safer interventions in favor of the older, more harmful. Contrary to ABM, acumen-based medicine, EBM offers us a framework that is unbiased, objective, and always open to scrutiny and correction. Let me end this segment with two thoughts. First, clinical acumen is not hindered by evidence-based medicine. Rather, acumen is constantly informed by the EBM framework. Dr. Cochrane believed that evidence could ensure we don't order unnecessary tests. Today, we call this initiative Choosing Wisely, a movement that's now been adopted nationally as a way of protecting patients against wasteful and harmful testing. EBM helps us make informed decisions within this capacity. Without EBM, there would be no Choosing Wisely. Second thought, evidence-based medicine cannot operate without the constant generation and interpretation of evidence. The prime directive, the oath we all swore, do no harm, simply cannot be done without EBM. Thank you.
It's an honor and pleasure to be on this stage today participating in the Travill debate. Although Dr. Archer and I may be on the opposite sides of this debate, we can both agree that as students we had the pleasure and the privilege of being taught by Dr. Travill. We were both blessed and transformed by that experience. Dr. Travill was a man who never took yes or no as an answer. For him, what was important was that you, the student, know and understand the reasons why. He felt that through understanding and connecting the dots, the student developed a greater knowledge and wisdom, and in doing so would be on the path to becoming a better clinician and a better person. A 73-year-old woman is lying on a stretcher in the emergency room with her left leg short and externally rotated. She's a type 2 diabetic with early dementia. She's two-pack smoker for 20 years. She has COPD. She's got bruising around her eyes. She's slightly confused. She has a blood pressure of 110/70. Her heart rate is 100 and irregular, and she's got a recent atrial fibrillation seen developing on her EKG. Her sodium level is 125. Welcome to clinical medicine. 300 times a year, a person like this arrives at KGH. She has a hip fracture. Each person is different. Each person is unique. Does she have a subcapital fracture? Has she lost consciousness? Does she need a CT scan of her head? What's that fuzzy shadow in her hilum on the chest x-ray? Is she fit for surgery? Has she had a recent myocardial infarct? How do we fix it? Do we use screws, unipolar, bipolar, total hip replacement? Do we use cement? Do we use non-cemented prosthesis? Do we use a lateral approach or posterior approach? Do we use general anesthetic or spinal anesthetic? There is no N of 1 clinical trial to direct our care. Evidence-based medicine says we should optimize her medical status and have surgery within 24 hours. Thank you very much for making this clear. The premise of our argument is that the practice of evidence-based medicine is an affront to clinical acumen because paradoxically, the advocates of evidence-based medicine devalue experiential evidence. Indeed, evidence is the core of clinical acumen. Evidence derived not only from empirical or evidence-based medicine, but also the science of medicine, but also the experiential evidence, the art of clinical practice. To the clinician, the best practice of medicine recognizes that the patient's best interests are served when the clinician embraces both the art and the science of medicine. Somehow, to the advocates of EBM, the concept of the art of medicine is a quaint nod to the past, that truth can only be found primarily through rigorous, evidence-based scientific study. This is an affront, as it disrespects the important balance of the art and the science in clinical practice. Evidence-based medicine is a medicine based on science. Claude Bernard, the most eminent medical scientist of his time, who introduced the concept of homeostasis, stated that art is I and science is we. Bertrand Russell, the philosopher, mathematician, and Nobel laureate, stated that science in the pursuit of truth is the equal but not the superior of the art. Osler, that quaint old Canadian clinician, stated over 100 years ago that the physician best schooled in the art of medicine understands that it is much more important to know what sort of patient has a disease than what sort of disease a patient has. Never has patient-centered medicine been more clearly defined. The premise that science reveals the truth, as advocated by EBM, informs the clinician of the patient's disease sort, that it is more important than the person affected by the disease. The affront to the clinician and to clinical acumen is not that evidence isn't of value. Evidence is of critical value to the patient and to the treating physician, the decision maker and decision makers. The evidence is of value to us because what is happening is we are being forced to place their experience, the experience, in a secondary or diminished position or devalued position, how to inform their decisions. Decisions to diagnose, to investigate, and to treat patients. Who is the clinician? What is our role? Many of us here today are studying or are wishing to become MDs. MD, as I was reminded in my youth, really stood for make decisions. The debate is really about how clinicians should make decisions. We can all agree that as clinicians, we want to do the best and greatest things that are best and greatest value to the patient, to their family, and to society in general. We can agree that as clinicians, our primary job is to meet the needs and interests of patients for whom we work. As such, the clinician wants a positive result. The clinician wants the decision to manage risk, maximize positive outcomes, and minimize the probability of poor outcomes. The clinician would like every patient to do well at a lower cost to society so as to husband our scarce economic resources to efficiently meet the needs of the many, not just the few. The practice of medicine is filled with uncertainty. However, uncertainty makes people feel uncomfortable. Nobody wants a bad outcome. Nobody wants to be labeled as a bad or poor clinician. So we seek evidence to support our decisions and our actions. We live in the computer age where information data acquisition and complete analysis through complex statistical analysis provide us with an avalanche of studies and treatises on all aspects of practice, cost-benefit analysis and improved diagnostic treatments and techniques for an ever-widening vista of diseases and disorders. The science can be overwhelming to the clinician at any stage of their career. The clinician is very tempted to feel uncertain, and to do the right thing, they go with the flow, because how wrong can you be if you follow the scientific evidence? The use of empirical evidence to support decisions is highly appealing, but evidence can be used like a drunken person uses a lamppost for either support or illumination. Decision-making is what we do as clinicians. The decision-making process has been elegantly described by philosophers and computer scientists. It first involves identifying the decision to be made, gathering the relevant information, identifying the alternatives and choices, weighing the evidence, choosing alternatives, taking action, and then reviewing the consequences. For the clinician to be effective to meet the patient's needs, clinical acumen is an absolute necessity to examine the patient, take a history, do a physical exam, and have the knowledge to understand what questions to ask to identify what is step one. What is the patient's problem? Clinical acumen requires an understanding of the experimental and the experiential evidence and connect the bits of information and knowledge to weigh and value the evidence. Weighing the evidence from all sources, from colleagues and other members of the healthcare teams, balancing the probabilities and assessing them requires knowledge, wisdom, and skill, as what affects the patient in front of you may actually not be the statistically likely choice. Taking action takes courage, but review of outcomes takes more courage, as we are responsible and accountable for the choices that we make, and some of those choices may lead to an undesirable outcome. Critical self-appraisal to evaluate the experience, to hone skills, refines clinical acumen, and improves decision-making. One may want to write a paper about that experience, but if not in print, it's still valuable, it's still valid. We look after people, science guides, but it should not dictate the practice. It becomes an affront when the practice guidelines become practice rules. Thank you.
Well, Dr. Rodan makes some very convincing arguments, ladies and gentlemen. I'd like to begin by thanking you all for being here, welcome the Travill family, and thank my colleagues for attending as well. I think although John makes these convincing arguments and is clearly sincere, I'd remind you of the words of George Burns, who said, "Sincerity is the key, John. If you can fake that, you get it made." So, in fact, you know, Dr. Rodan would have already won this debate, but for the fact the year is not 1600. Were it 1600, the Earth would be at the center of the universe. There would be no gravity, there would be no bacteria, and women, instead of voting or comprising half of the Canadian cabinet, would be busily being burned at the stake for witchcraft. In that year, John, and no year since, your logic would have prevailed. To answer Dr. Rodan's implicit question, why do we need evidence-based medicine, let me borrow a phrase from the newly minted Prime Minister Trudeau. Why do we need EBM? Because it's 2015. Thomas and Dr. Rodan have constructed an argument that presupposes evidence-based medicine is locked in time and somehow an obligatory conflict with acumen-based medicine. They would have you suppose that evidence-based medicine in 2015 will be the evidence-based medicine of 2020. In fact, evidence is always changing. Rather, it is their beloved acumen, an acumen-based medicine that evolves at a glacial pace, if at all. Evidence-based medicine is like a river. At its wellspring are our ancient colleagues. They struggled to understand disease and find cures, but they were handicapped by the absence of a framework which allowed them to discover and test their discoveries, which is the base of modern evidence-based medicine. Now, Thomas and Dr. Rodan would have been comfortable in 420 BC, when Hippocrates of Kos proposed that diseases have natural causes rather than being visited upon us by the gods. They would have loved to have been doctors in 200 AD when Galen was at his peak and taught that clinical medicine should be based on experience. Galen and Rodan both support acumen as the basis for medicine. However, Thomas and Dr. Rodan would have started to twitch during the Enlightenment when Paracelsus, Vesalius, and Harvey began to use evidence as the basis for medicine. As the river of medicine runs its course, it's sculpted by evidence. Let's move downstream to the 20th century and rejoin the man who's credited with founding evidence-based medicine, the late Dr. David Sackett. You've all heard of him, but probably many of you don't know that he was actually an American from Chicago, although he eventually took Canadian citizenship. He trained in an era of acumen-based medicine, one in which our worthy opponents are apparently still mired. Sackett's first recognized the limits of acumen and experience when confronted with a teenage patient suffering from hepatitis A. Acumen, or conventional wisdom, caused him to prescribe the youth strict bed rest. When the young man objected to strict bed rest, Sackett reviewed the literature and found a randomized clinical trial. The trial randomly assigned soldiers with hepatitis into two groups, one receiving bed rest and the other regular activity. The study found the groups had precisely the same outcomes. In other words, there was no evidence that bed rest was useful. The conventional wisdom was bunk. Sackett discovered the power of evidence, an epiphany that changed his life and eventually the practice of medicine for most of us. Sackett Sackett famously said, half of what you'll learn in medical school will be shown to be either dead wrong or out of date within 5 years of your graduation. The trouble is, no one can tell you which half. When John and I graduated from Queen's Medical School in 1981, we were taught that patients over the age of 65 years could not undergo heart surgery, that beta blockers were contraindicated for heart failure, and that prolonged bed rest was essential for the care of the heart attack patient. We learned these acumen-based lessons, and they were all subsequently shown to be wrong. Dr. Sackett was in fact making a pitch for the ongoing refinement of acumen by evidence. How do we inform acumen? Well, we make carefully designed clinical trials. The trials enroll relevant patients, have meaningful endpoints. They should use placebo controls. And of course, there should be rigorous blinding of the investigators to prevent what Dr. Cron mentioned, which is the insidious effects of industry. The results should be subjected to appropriate statistical analysis, which is something that acumen struggles with N-of-1 decisions. That analysis ensures that the observed findings are not the result of the play of chance. Finally, the results must be subjected to rigorous peer review. The last step is quite interesting. It's called knowledge translation. The product of evidence-based medicine is transmitted to medical students like Thomas and surgeons like Dr. Redan and becomes the source of their acumen. So with these self-evident virtues, why would Thomas and Dr. Redan oppose evidence-based medicine? Perhaps it's because evidence-based medicine is riskier. The medical establishment does not reward doctors who debunk traditional methods. Their new evidence may help the patient, but it rocks the medical boat. Let me offer a story that illustrates the risk that practitioners of evidence-based medicine take as they blaze new trails. The year is 1846. Dr. Ignaz Semmelweis, a Hungarian physician, is director of the maternity clinic at the Vienna General Hospital. Based on careful measurements, he's noted for several years that women whose babies were delivered by midwives had much less puerperal sepsis than babies delivered by MDs, 11% versus 3%. Using acumen, he postulated the problem was hand hygiene. He had noted that the doctors, the MDs, had come to the maternity ward directly from surgery or autopsy with blood and fluids on their hands and gowns. Although germ theory was yet to be discovered, he reasoned that hand hygiene must be important. So he did an experiment. That's evidence-based medicine. He placed a hand-washing basin at the head of the ward. He instructed his colleagues to use it. This simple intervention virtually eliminated puerperal sepsis. However, his acumen-based medical colleagues were not amused. They drove him from the hospital and hounded him until he lost his sanity. Tragically, Semmelweis died in an insane asylum. Hopefully we won't suffer that. However, because of his evidence-based contributions, we now wash our hands before and after each patient encounter. So let me come back to our opponent's perception that somehow refining practice through evidence is an insult to the doctor's acumen. Now, there are two flaws with this argument. First, without evidence, acumen often confuses association with causation. Scholars such as Samuel Johnson, also known as Dr. Johnson, have long recognized this. Now, Dr. Johnson was not a physician. Rather, he was a noted Oxford faculty member and literary critic in the 18th century. Getting back to Jennifer's point, actually, Dr. Johnson was the author of the world's premier English dictionary prior to the Oxford English Dictionary. In any case, Dr. Johnson was quite famous for critiquing a medical book called The Essay on Waters. This book was written by one Dr. Lucas, and in this book, Dr. Lucas was promoting an immersion of the elderly in cold water to treat their ailments. Lucas noted, "The old gentleman that uses the cold bath enjoys in return an uninterrupted state of health." Dr. Johnson skewered Lucas based on the lack of evidence for this practice, noting, "The instance of an old man enjoying health does not prove the cold bath produced health, but only that it does not always destroy it. He is well with the bath, he would have been well without it." Johnson goes on to say Lucas's experiments were worthless, no measurements were taken, and there were no controls. What Dr. Johnson knew in the 18th century apparently eludes our worthy opponents in 2015. Second, evidence-based medicine actually embraces clinical acumen, although admittedly it is more work. The year is 1962. Dr. James Black is working hard to find an effective treatment for angina pectoris, the chest pain that is caused by narrowing of coronary arteries and the resulting inadequacy of blood supply to the heart. In his day, there was only one effective treatment, and that was sublingual nitroglycerin pills. Nitroglycerin reduces angina by dilating coronary arteries and increasing blood flow to the heart. Now, Black's acumen, which we also support as being extremely valuable, told him that angina might alternatively be approached as a mismatch between blood supply to the heart and the heart's demand for oxygen-rich blood, which is determined primarily by heart rate. He decided to try and slow the rate of the heart and thereby reduce the heart's fuel demand. He began designing antagonists to adrenaline. And he developed the adrenaline blocker propranolol. By the way, adrenaline, in case you don't know, is the fight or flight hormone produced by the adrenal gland in response to fear, which parenthetically I suspect Thomas and Dr. Rodan may be experiencing at the moment. These drugs revolutionized coronary care. Black's work replaced the earlier acumen-based management strategy that accepted the status quo and consigned angina patients to odd diets, bed rest, and occasional sublingual nitroglycerin. When Black was asked how he did this, he simply said, hard work. And John, this reminds me of a poem by Henry Wadsworth Longfellow. The heights by great men reached and kept were not achieved by sudden flight, but they, while their companions slept, were toiling upward in the night. So, evidence-based medicine is more work, but it's worth the effort because it creates a self-renewing, ever-evolving source of medical knowledge. Thank you.
Clinical acumen is an acquired skill, allowing the clinician to make insightful decisions. Decisions which rely on the clinician to be inclusive and open to all evidence, whether that be evidence from the lab, but also experiential evidence, something that is lacking in EBM. Those can be provided by members of the healthcare team, evidence provided by the healthcare team, and balancing and weighing the evidence and acting upon the conclusion. Evidence-based medicine is extremely important, but it is a tool to be used to supplement and to augment the physician's decision-making process. It is informative, but not prescriptive. Clinical acumen has taught us that evidence is not necessarily truth. Probability is not certainty, and statistics, as Disraeli tells us, can sometimes lie. The art of medicine and its practice relies on clinical acumen based on an understanding that the clinician must, as well as being a scientist, must be an artist. Einstein said, "I am enough of an artist to draw freely from my imagination. Medicine as a science is based on an understanding of both the empiric and the experimental evidence. Clinical acumen is informed by both. The art of medicine and the practice of medicine is not an antiquated notion now to be subordinated by the weight of evidence-based medicine. Medicine advancing comes closer to the truth when the clinician uses them in equal measure. To paraphrase Newton, we see further when we stand on the shoulders of those quaint old giants of the past. Our future insights and progress will occur as a new generation of giants follow the advice and wisdom of their forebears, building a better understanding of the patient with the disease and not the bits of information." Thank you.
Well, let me close by reiterating a few points. First, there is no tension between acumen and evidence-based medicine, so long as acumen is informed by evidence. Evidence-based medicine provides an ideal framework in which ideas identified by acumen can be refined, tested, and either accepted or cast aside. Second, medicine is constantly evolving. In Ontario, we spend $50 billion a year on healthcare. There's substantial waste, as Jennifer told you, on money and harm to patients caused by ordering tests and performing procedures for which there is no evidence. To counteract these excesses, there's a national movement, as you've heard, called Choosing Wisely Canada. This requires we select the minimal effective slate of tests and procedures for our patients. To choose wisely, surely we must have a body of evidence as a guide. Third, our opponent's case, our worthy opponent's case, is divorced from reality. Railing against evidence-based medicine in 2015 is as futile as arguing for the repeal of the law of gravity. As physicians, we are required by Health Canada to present evidence to obtain approval for any new drug or device. Were our opponents to be victorious tonight, God forbid, we should suggest the audience drive their horses and buggies over to the new medical building where they will undergo bloodletting and have a few leeches applied to their skin. In fact, evidence-based medicine is widely accepted by everyone except for a minority of Luddites within the medical profession. In conclusion, let me recite a limerick I wrote on this special occasion in honor of my friend, Dr. Redan. There once was a surgeon from Queens who on evidence was not very keen. How does one choose wisely with no proof to guide thee? A roll of the dice? So it seems.
Well, my goodness, that was fabulous. If we can start the wrap-up by please joining me in a healthy round of applause for our 4 debaters. So as I say, there are no winners and losers, but just to understand how much people were swayed, if we could see a show of hands, how many of you now support the resolution that evidence-based medicine is an affront? No, Stephen, you can't do that. Is an affront to clinical acumen. How many now support it? Okay, and with a show of hands, how many are opposed to the resolution that evidence-based medicine is an affront to clinical-based medicine, or clinical acumen? Okay, well, thank you. We now know exactly where we stand, and we welcome you all to the University Club, and we'll invite the Travills, along with our debaters, for a few photographs. And once again, Chris, thank you and your team for a wonderful evening.